My name is Sarah Stock, and I am an MSN student at Eastern Kentucky University. I am currently studying to become a psychiatric mental health nurse practitioner, and I would like to share my Integrative Review PowerPoint presentation. An emerging healthcare concern that advanced practice nurses will encounter is depression among adolescents. Depression is defined by the National Institute of Mental Health as a common but serious mood disorder caused by a combination of genetic, biological, environmental, and psychological factors. The prevalence of depression among adolescents is a crucial problem. The National Institute of Mental Health reported in 2015 an estimated 3 million adolescents aged 12 to 17 experienced at least one major depressive episode the previous year, representing 12.5% of this vulnerable population. In addition, there is notable national and global support from organizations such as the World Health Organization, or WHO, that has developed goals and resources to support depression in adolescents. WHO also illustrates importance by publishing studies reporting half of all individuals who develop mental disorders have their first symptom by age 14. A literature search was conducted to answer the clinical question, in adolescents diagnosed with depression, how does incorporating cognitive behavioral therapy, or CBT, compared to treatment as usual, or TAU, affect depression symptoms within 6 months? The first study selected from the literature review was by Emsley et in 2015. The authors conducted a randomized control trial to evaluate the continued effect of a sequential treatment strategy of fluoxetine followed by continued medication plus the intervention of relapse prevention, CBT, to determine effects on relapse prevention beyond the treatment phase. The intervention was compared to the control group of medication management only. The total sample population was 144 youth aged 8 to 17 who were in an outpatients and a general pediatric psychiatric outpatient clinic. Study findings showed significantly lower risk of relapse in the medication management plus CBT group versus the control group throughout the 78-week follow-up period. In addition, during the 78-week follow-up period, the mean time to relapse for medication management plus CBT was 64.40 weeks, compared to just medication management with 50.93 weeks. The second study selected from the literature review was by Jensen et al. 2014. The authors also conducted a randomized controlled trial evaluating the effectiveness of trauma-forced CBT compared to treatment as usual for youth. The primary outcome measures for the research article was post-traumatic stress symptoms, although the study was relevant for adolescents with depression because it illustrated secondary outcome measures including depression. The research method consisted of an intervention group who received the TF-CBT for 12 to 15 sessions, integrating cognitive, behavioral, interpersonal, and family therapy and trauma interventions were discussed. The control group asked therapists to provide treatment or therapy as usual for 12 to 15 sessions. The total sample population was 156 traumatized youth aged 10 to 18 years old from community mental health clinics for children and adolescents in Norway. The scales used to measure depression was a mood and feelings questionnaire, a self-reported questionnaire that consists of 34 items measuring full range of the DSM-4 diagnostic criteria for depressive disorder. Study findings revealed participants in the TF-CBT scored significantly lower than the TAU on depressive symptoms. These studies both contribute to the evidence-based knowledge of implementing CBT as an intervention for adolescents with depression and therefore add great value for nursing practice. Evidence-based practice is needed in nursing practice to deliver the highest quality of healthcare and ensure the best patient outcomes. The study showed synthesis to support improved nursing practice, including in Jensen et al. 2014. It revealed strong application evidence by the youth receiving TF-CBT reporting significantly lower levels of depression compared to the control. And furthermore, post-traumatic stress often co-occurs with other disorders such as depression. Emsley et al. 2015 also illustrated strong application evidence by findings of adding CBT after treatment responses to medication improves outcomes and not just in the actual continuation treatment, but also has positive effects up to a year after therapy. From professional experiences, I have observed frontline treatment for adolescents with depression consisting of psychotropic medications or frequent medication changes and therapy not based from CBT therapy model. As the findings from the research studies have shown, an intervention proposed to change this area of nursing practice is advanced practice nursing implementing treatment with CBT for adolescents with depression as a principal or first-line intervention. A healthcare environment or setting appropriate for implementation of the identified intervention by advanced practice nursing would be a nurse-managed community mental health center. Nurse-managed community health centers focus on primary care delivered by nurses and represent an ideal setting for a variety of services, including screenings to detect health risks, health promotion and prevention counseling, and interventions to promote healthy lifestyles such as CBT. That's all, so thank you for your time, and please send me a discussion board post with any questions or concerns. Thank you.